থাকবে না। হ্যাঁ, ওই সাইটে আপনি শুরু করেন।
আসসালামু আলাইকুম, আশা করি ল্যান্ডসেট পরিবারের সবাই ভালো আছেন। আজকে আমাদের ক্লাসের টপিক ইলেকট্রোলাইট ইমব্যালেন্স। ক্লাস নিচ্ছেন সুদূর ইংল্যান্ড থেকে ডক্টর মঞ্জুর শওকত, ইম্পেরিয়াল কলেজ স্কুল অফ মেডিসিন, লন্ডন। স্যার, প্লিজ আজকে আপনি ক্লাস শুরু করতে পারেন এখন।
Very good evening to doctors in Bangladesh, and many thanks to Lancet Group to invite me for this talk. And what I'm actually looking forward to do this talk is more of interactive, and please feel free to join in the discussion. And if you are interactive with me, probably the more talk will be more interesting. And if you see here that my slides, the first slide, if you see the bottom left, that's where Sir Alexander Fleming invented his penicillin. This is actually, he used to work from now Imperial College, that's St. Mary's Hospital, then is one of our hospital, and I cover and some days in St. Mary's Hospital. So, and he invented penicillin in that building. If you visit London, you'll be very welcome to see this, the very historic thing, how penicillin was invented, and you can see the labs there. I'm mainly based in Hammersmith Hospital, London, and also I cross-cover Charing Cross Hospital and St. Mary's Hospital. And if you see on the bottom, in the top left, and if you can see Lady Diana holding Prince William, future King of British UK future king, and Princess Catherine holding another future king, Prince George. And actually, both of them actually born in our hospital, in the Lindo Wing and St. Mary's Hospital. So with regards to like history, Imperial has got a lot of history in kind of innovation, and also in COVID-19 pandemic. We are the university which actually developed this mathematical model, epidemiological model for COVID, and lots of innovation is happening at Imperial. So let's move to my first slide. It's like, 1 second. The learning objective of this talk would be first understanding serum sodium abnormalities. Like I mentioned, the electrolyte abnormalities, and it is impossible to cover all the electrolytes in an hour talk. So, and I have decided to make it more a kind of comprehensive, more about the sodium abnormalities today's talk. And another learning objective from this talk would be understanding about the fluid balance and with electrolytes, and then about clear understanding of normal saline infusion. Because when somebody's sodium is low, one of the things we commonly do is start giving not 9% saline infusion. And you will later in the few slides, you will understand when actually can you use saline, and which concentration, and when to avoid infusing saline. So if I ask you that what is the commonest electrolyte abnormalities in hospital patients, anybody can answer me that, please. Which is the most common electrolyte? Anybody? Is actually low sodium is the commonest electrolyte abnormalities in the hospitalized patient. And if you ask me how common this problem, you will be surprised to see that how common that low sodium. 1 in 4 patients actually admitted when they are in hospital in the inpatient, 1 in 4 patients is actually low sodium. So you see what a big burden. And if we miss the diagnosis, this problem, hyponatremia, when serum sodium level goes down below 135 millimole, then we call it hyponatremia. or low. And this is the commonest electrolyte abnormalities in the hospital. And whenever we find any patient or any, one of the things I think probably we need to think about, what is the underground mechanism, what actually causing this problem? And they're causing this disease, why we are actually seeing the symptom on the patient or signs. We ask the first question, what are the actually main cause or mechanism behind this problem? It will actually help us to become a very slick doctor, and it will help us to become a very good clinician. So if I ask you what is the underground pathophysiology of hyponatremia, can anybody answer me? So I'll be happy if you can answer. Or if you can write in the chat box, what is the underlying pathophysiology of hyponatremia or low sodium? Anybody? Please, I'll be happy to see if any answer is coming from the audience. You can write in the chat box. And I can actually, yeah, I can see any response. Suman Das, I can see Suman Das. Do you know anything, any underlying pathophysiology of hyponatremia, or anyone, please? Don't be shy. You know, if you are not managing any patient at the moment, you are with me. So we are not going to do any harm to any patient because we are talking. And as I mentioned this, if we are interactive, that it will help you to understand better about the mechanism of the disease.
CIAT may be a cause.
Sorry?
CIAT, syndrome of inactivated.
CIAT is a cause. Okay, what's your name, please?
Shuman Das.
Shuman, thank you very much being a first participant to join in the discussion. So CIAT is one of the common cause for hyponatremia or low potassium, but it is not the mechanism of pathophysiology. Well done, but you know one of the causes of low potassium is CIAT. I'll go to the CIAT, why we get actually CIAT, we'll go to that. The underlying pathophysiology of low potassium is increased extracellular water. It might sound a bit interesting. We are talking about the low potassium. Monju, you're saying about increased extracellular water. Actually, look at these two slides, one on the left and one on the right. Shuman, what is the difference between one on the left and one on the right? Do you see any obvious difference between two? Whatever you see, don't worry, that's be interactive, because I found that you just, you just brave the many others of your friends or colleagues. Any difference have you seen, or both are same? What's the glass size of both? Is both glass size are normal, same, or one is larger, one is smaller?
So the left one seems smaller.
Okay, and right one, bigger. Well done. What's your name, please?
Saifi, sir.
Okay, fantastic. So if we look at now the spoon with salt, do you see any difference, or both are the same size? Both are same size. So as I mentioned, low potassium or hyponatremia is not a problem with salt, it's problem with water. If you look on the left, at the less water in a small size glass, and on the right is the bigger size glass and more water and similar amount of same. So they actually, and because of the huge volume of water, actually make the salt diluted. So hyponatremia or low potassium is not a salt problem, it is water problem. Lots of clinicians in clinical practice, I'm forgetting about the medical student or junior doctors, even senior clinician make a blunder of understanding of low sodium. So which hormone controls water balance? You already got answer. Please be interactive. So I will, I'll get more energy and I will find more interesting to share my knowledge with you. Which hormone control water balance? Fantastic, Shuman. Well done, Shuman. So, okay. So, and look, this is the slide. You can say control of water balance. Whenever you think about low sodium, you need to understand about how our water in our body is actually balanced. So which hormone control water balance is ADH. So when ADH is actually released from posterior pituitary gland, is actually working on the distal tubule and kidney tubules, and through the water channel and aquaporin too, its jobs to retain water. Mainly ADH work in our body is through that channel. Okay. So, which means more ADH is retaining in our body. That means ADH, what it does, ADH retain more water. So more water, excess ADH means excess water. That means if ADH is actually retain more, if more ADH secrete from the posterior pituitary, that means our body actually absorb more water. More extracellular water or excess water causing low sodium. This is one of the key slides during today's talk. Please. Try to understand is and low sodium or hyponatremia is not a solved problem, it's problem with water. So if for any reason, if our body release more ADH, that means our body get more water. Excess ADH, excess water. That means salt become dilute. So potassium will be low. Quickly, I'm showing the ADH mechanism. So in the body, in our body, it works to two receptors in V2 and V1 receptor. And V2 receptor actually acts on collecting that of distal insertion of aquaporin that actually helps. And V1 receptor is actually works on vascular smooth muscle, causing vasoconstriction in higher concentration. Or its alternative name is vasopressin. Okay. So in ADH secretion, now you might ask, Manju, why our body actually release ADH? For two stimuli. One, if serum osmolality is more, and this system is actually mediated by hypothalamic osmoreceptor. And another is if our blood volume or blood pressure is low, is mediated by baroreceptors, in which you find in carotid, aorta, and atria, which you have read in anatomy. So what you are trying to apply your anatomy knowledge in clinical medicine. So serum osmolality and is actually one of the stimulus to release ADH from posterior pituitary. Another was when blood pressure is low, and it actually through the baroreceptor, what it tried to do, to increase blood pressure, and because of that, body release. Okay? So you can see the same thing what I told. So when you have got more serum osmolality, and then you feel thirsty and you drink plenty of water. Okay, when the blood pressure is low, or volume is low, and the baroreceptor, and they actually send stimulus to the posterior to release water, ADH, and the more ADH, which means more water. And what is the effect of increased ADH secretion? It causes hyponatremia. So the first slide, I showed one of the slides, and can somebody tell me what is the difference between these? Which one is larger, which one is smaller? Top one or bottom one is larger? Which one is larger, please?
The bottom one is larger, sir.
Fantastic. Any difference of amount of salt? Any difference with amount of salt? No difference. So in one glass, you have got more water, and the bottom one and the top one, you have got less water, but a similar amount of salt. So that means the bottom one has increased water reabsorption, which means when ADH is released, in more ADH, more water, and more water in our extracellular fluid, that means low sodium. So when you see any patient report of hyponatremia, what is the first step in clinical assessment you do? Anybody can ask it if you do low potassium. Don't worry, try to be interactive. If you make mistake, I'll correct you. And that's how I learned, and I have requested you to learn. Is if you are in interaction, so you can learn better. If you see anybody's low sodium, what is the first step of clinical assessment you do? Volume status. Okay. So whenever you see any patient in your clinical practice, or if you are a medical student, you are seeing a patient in a ward, and you're seeing the report of the patient has got low potassium, low sodium. So your first step is to do a volume status. And how actually we do volume status? And actually there are some clinical signs for hypovolemia. This is how actually we assess patient in the ward in hospital. And here, when somebody has got low volume, they become tachycardic. They develop postural hypotension, and which means that there will be the differences of blood pressure, sitting, standing, and sitting blood pressure. And it is actually when somebody is low potassium, they are not the right patient, they're very weak. They will not be very keen to help you to go, okay, you can record my blood pressure while I'm standing. And then you can notice reduced skin turgor. These are all signs. You can read in textbook, and also you can, if you look at their mouth, they have got dry mucous membrane. And they are a bit confused or drowsiness because of low volume. There is not enough fluid in the brain, so they feel a bit confused or drowsy. And even if you look at their urine, if they are on catheter, you'll notice also that they have got low reduced urine output. You might ask the person, how is your urine? Is it passing urine normally, or do you think it's going a bit less than normal? All these the signs I have mentioned, none of them are actually reliable. None of them are reliable. And like after an hour talk, and if you assess me, I might have a dry mucous membrane because of kind of like talking for an hour. I might be dry. Even if you assess somebody is the old patient and they have got reduced skin turgor, so they are not reliable. So who can tell me which is the most reliable thing to know about the low potassium? Anybody have any answer? I just want to, don't worry if you cannot answer me, but I just want to say you suggest me for cause. How do you actually get to clue about that? This potassium is a really low potassium. Anything you want to do? Please, I'll be happy if you make mistake. So nobody is seeing your face, so don't worry who's talking. I'm not asking your name, just say. And what is the most reliable thing to confirm that your patient has really a low sodium? Any suggestion?
Features of CNS CNS disturbance, CNS drowsiness.
I mentioned already, CNS drowsiness, none of them are actually reliable. Any other? Well done, try, Shumon, and you tried. Any other suggestion from anyone?
Low BP.
Low BP, as I already mentioned, it's a low postural hypertension, low BP. Well, this is also not very reliable. Any other suggestion, please join. And if you join in the discussion, I think probably it will help you to better understanding of this problem. This low sodium problem is not very easy, Any other suggestions, please?
Pedal edema.
That's actually that's not a low volume. That's the high volume. Any other? You make mistake, then that's how you actually learn. Making mistakes is a good way of learning things. Any other? Say, I just need one more person, then I'll move to the next slide. Any other?
Dehydration?
No, dehydration actually giving you the dry mucous membrane. So low urine sodium, okay? So when you see somebody's blood test, sodium is low sodium. And if you do urine sodium, that will actually, if urine sodium is less than 20 millimole, that will confirm you actually patient is really have got low sodium. So once patient admitted hospital, so what we're gonna do is start, okay, low potassium, low sodium from blood test and all other things, we start keeping some saline and start something. If you start doing urine sodium after starting saline, that you will not get a real impression. So you need to take cardiac urine sample before you actually starting normal saline. If you think that is a low sodium, so you need to actually collect urine sample before actually you start saline. And also, so whenever you see any patient with low sodium, you need to do one thing, and that is you need to also check his urine sodium level. That will confirm and whether the patient is hyponatremia. If is urine sodium is not less than 20 millimole, that maybe there is some problem with laboratory is analyzing serum sodium level. Okay, so you can apply the urine sodium level only all patients apart from those who are on diuretics. Those who are on diuretics, you shouldn't rely on low urine sodium. You obviously trying to see more than 20 milliliter of sodium. In diuresis, what we are trying to do is offload our lungs or, offloading our body from water. So when water loses, it also takes sodium. So this is applicable to check hyponatremia if patient not on diuretics. And for any other causes, if you check, if urine sodium is less than 20 millimole, then you can very confidently say, yes, this patient has got hyponatremia. Is it clear to you? Is it clear? Is it clear to you?
Yes, sir.
Okay, I'm going a bit slower. The reason I'm going a bit slower because this is a very complex issue to understand. So if everybody is happy, I'm moving to next slide. So whenever you see any patient's blood, sodium is low, then what you need to do, and that patient is not on diuretics, what you need to do before actually start giving any saline, you need to check urine sodium level. If urine sodium level is less than 20 millimole, then you can very confidently say there is no laboratory error. This patient has got low sodium. Now I'm coming to clinical sign of hypernatremia when sodium is more. So signs of hypernatremia, they have got raised jugular venous pressure, and then they have got pedal edema. So someone mentioned pedal edema, it is not for low volume, it is for high volume. Okay, and also if this is on X-ray, you can see somebody with a heart failure, pulmonary edema patient. If you look at the right line, you can clearly see there is fluid in the horizontal pressure plus opacity. So the fluid in the horizontal pressure is one of the key findings. If you suspect somebody with edema, radiological or clinical, they could have. Now, how we actually address or deal with a hyponatremia patient. So what we need to do, we need to first thing to do volume assessment. I mentioned earlier the volume assessment, all the sign tachycardia, confusion, or blood pressure, low blood pressure, or less skin tartar, or all those things I mentioned, dry mucous membrane, that are not actually reliable for actually harming that the patient is got sodium. So volume status is giving us a guideline. So whenever you see any patient with low sodium or hyponatremia, your first task is to do the volume assessment. Whether the patient's volume is hypovolemic, it's one category. Whether the patient is euvolemic, volume is fine. Whether the patient is hypervolemic. So whenever you see any patient with low sodium is low, you need to think about three. One is low volume or hypovolemic, ask yourself. Second, euvolemic, and third is hypervolemic. So now going to a few causes of hypovolemic or low volume. This is very common you come across or encounter in clinical practice. Diarrhea is one of the common causes of low volume, and then vomiting and diuretics and salt-losing enteropathy. These are the patients, they have got low sodium as well as their volume in body is low. So this is one category. Now, second one is euvolemic. That is, there is no problem with the volume. It's not hypovolemic, it's not hypervolemic. Can someone tell me the few causes of this one, euvolemic? I've already got to know one cause. One of your friends told me already at the beginning of the talk. Can you tell me?
Hypothyroidism.
Okay. Huh?
Hypothyroidism. Euvolemic.
Fantastic, fantastic. Any other cause? Well done.
Primary polydipsia.
Huh?
Primary polydipsia.
Primary polydipsia, okay. Any other? Try, make mistake. If you make mistake, then you will understand better. Hypothyroidism, any other two causes? Tell me two common causes.
Excessive electrolyte-free water infusion.
Sorry?
Excessive electrolyte-free water infusion.
Okay. I'm not saying yes or no, okay? Any other?
SIAD.
Fantastic. Who said that SIAD? Three most commonest cause in clinical practice, you see patient, either they have hypothyroid, low and hypothyroid. And second one is another common cause, adrenal insufficiency. And SIAD, we actually get lots of SIAD patient in clinical practice. I'll go through the details of SIAD and how actually you can exclude one from. So well done. I have got one answer from the group, hypothyroid, and then another common cause is adrenal insufficiency, another cause is SIAD. And now hypervolemic. So, and hypervolemic is all failure, cardiac failure, nephrotic syndrome, or cirrhosis of liver. Okay, so now we have actually, what I would say, divided in three cohorts. One is hypovolemic patient. They have got low sodium. The common reason for these are diarrhea, vomiting, diuretics, salt-losing enteropathy. And the middle group, they have got volume is fine, but low potassium. Hypothyroidism, adrenal insufficiency, and SIAD. And then we have got another category is those who have got low potassium, but volume is high. So if they are cardiac failure, heart failure, or kidney failure, or nephrotic syndrome, or cirrhosis, or liver failure, okay? So whenever you see any hyponatremia patient, if you see, read a blood report and serum sodium is low, your first task is to do, I need to do volume assessment, okay? So which physicians are very good at assessing volume? Which doctors good? Which specialists are good at assessing volume? Any answer? Like we have got cardiologists, nephrologists, then hepatologists, then anesthetic, critical care, and all this, who are very good in assessing volume. Any answer, please? Make mistake, don't worry. Sorry? Fantastic, well done, well done. I'm very impressed. So how accurate they are assessing when they do volume assessment? What percentage of renal physicians are very good at actually assessing volume status of patient? 50, 60, 20, 30, 80, 90, 100%. Say, guess. I'm checking your guess action and how actually good are guessing. Say something, please. What percentage of the renal physicians are good at assessing doing volume assessment? 20%, 30%, 40%, 50%, 60%, 70%, 80%, 90%, or 100%? Random guess. Say something, please. Anyone? So around 48%, not even 50% of renal physicians, those who are very good at assessing volume, they make mistake assessing volume. So if you rely on volume assessment, without doing any urinary sodium, that's problem managing or diagnosing your low sodium. So now this is a bit complicated slide. You need to put a little bit more concentration, try to understand this one. On the top one, and what you see here, and the dots are salt and the empty space are water. This is somebody with euvolemia patient, okay? On the middle one, you see hypovolemia patient, and you see as salt is less. And when you compare it euvolemia patient, and the bottom one, it is increased water retention and reduced sodium. And how could you actually be hypovolemic but excess water? I mentioned at the very beginning, am I contradicting you? I mentioned more water, more ADH, more water. Now I'm talking about low volume and low salt, okay? So when somebody develops hypovolemia because of like diarrhea or the vomit, what they tend to lose, they lose water at the same time. They look at the middle one, they also lose water and salt both. So when you lose salt and salt and water from the body, which hormone get activated and released from our body? ADH released from our body. So what is actually, if you look at the bottom slide, the ADH's function is to actually retain water in our body. So, and this is how actually, this mechanism works like that way. So patient is hypovolemic and losing both salt and water, but because of ADH, it's trying to retain more water. So, but there is no more salt. So that's why you get increased water retention, but low sodium. So, and now, what are the causes of hyponatremia in hypervolemic patient? As we mentioned, one is heart failure, one is cirrhosis of liver. So you might ask, Moncho, why is somebody with a heart failure patient, heart failure, low potassium? Can anybody answer me this question, please?
Activation of renin-angiotensin-aldosterone system causes retention of sodium and water both. It causes hypervolemia.
Okay, well, good. Any other reason? Any other reason? Good. What happened to somebody with heart failure patient? Heart failure patient, what they develop? They develop actually a low perfusion, especially in case of systolic type of heart failure. And perfusion is low, so pumping activity get lower, low perfusion, blood pressure get lower. As if you can remember the slide from the beginning, when that blood pressure go down, then baroreceptor and actually send signals to the posterior pituitary to release more water. ADH, and ADH's function is ADH, more ADH, which means more water. Okay. Now, what are the causes of somebody with cirrhosis and they develop low sodium? Any idea, please? What happened to cirrhosis? In cirrhosis, what happened? There will be increased nitric oxide in. One of the causes of nitric oxide is lower blood pressure. When blood pressure gets low, through the baroreceptor, it sends signals to the posterior pituitary to release ADH. ADH equals water. More ADH is releasing in the body, more water. What happened with somebody with kidney failure or renal failure patient? Kidney failure patient, their actually excretion function is compromised. They cannot actually release more water from the body. Eventually, there will be more water retaining in our body. This is the mechanism for somebody with patient, kidney failure patient, and cirrhotic patient. They are hypervolemic. At the same time, they become hyponatremic. So now, very interesting one. This is something you'll be probably tested. I'm not quite sure about the tested in Bangladesh. This is one of the common things very frequently we test in the exams in the West. What are the common causes of a hyponatremic euvolemic patient? You already know, and this hypothyroidism. And because of hypothyroid problem, contractile function of the heart become a bit slower, and blood pressure can become low, and eventually it can send signals to baroreceptor to release more ADH. And now adrenal insufficiency, there is less release of cortisol. The cortisol, one of the main functions to clear water from our body. Because less cortisol is releasing from our hormone is releasing, eventually more retention of water. That's why somebody with adrenal insufficiency, you got actually low potassium. And syndrome of inappropriate ADH. This is the very, very common things. Even you see patient, CR, how common it is. You even cannot understand. You treat a CR patient, but you even can think about you treat a CR patient, you actually understand that such a common things happening in everyday practice. Lots of time we miss CR. Who can tell me about little bit about CR? I know I got a couple of answer from the audience. They mentioned that syndrome of inappropriate CR is one of the causes of low sodium. Shimon, can you tell me anything about CR? What do you know about CR? Or anyone else? So CR is syndrome of inappropriate ADH. It's not actually releasing of posterior pituitary, but our body is actually producing ADH, and you'll see releasing circulation in antidiuretic hormone or ADH, but it's not coming from the posterior pituitary. It's coming syndrome of inappropriate. It's not the reason why when we get normally get. So you can tell, or somebody low sodium, you say CR. If you see low, okay, so sorry. Miss one of my slides. So we can call it CR if somebody have got low potassium, If somebody has got low sodium and they are euvolemic and they are hypothyroid, they are adrenal insufficient, and they are or any kind of malignancy, then you can. So the causes of SIAD, and either it could be a problem, either it could be a problem with CNS problem, common causes if you see, it could be SIAD is coming, there is some problem, you've got euvolemic patient, you did volume assessment, euvolemic patient, you have got low potassium, so you need to figure out what actually causing, what organ is actually responsible for SIAD. It could be maybe due to the CNS pathology, or it could be due to lung pathology, or it could be due to like patient, or it could be due to some kind of tumors, or it could be due to surgery. Okay. Now I'm giving you a case study. So you've got a patient, and it's a euvolemic patient, and patient has got low serum sodium, and you actually try to work out, well, it's a euvolemic patient and low sodium, and you figure out all those pathologies, and a diagnosis is here. You figure out all these pathologies. There is no problem. You didn't find any actually causes, all the reasons I have mentioned. So you had CT head report is normal, chest, abdo, and pelvis CT scan is normal, and patient is 60 years old lady. What is your next step to diagnose this problem? This is a real life, we miss this kind of patient. You actually, check patient, all the report. You didn't find any, what you found, the patient is euvolemic and patient is low sodium. You have checked all reports, CT head normal, chest CT normal, pelvic CT normal, and patient is 60 years old lady. What would you do next? I really want to get interactive with this case, okay? Any answer, please make mistake. Any? So this is something, you have got sitting in some kind of exam. So what is your next step to do? You have tried to rule out, there is no problem with brain, no brain tumor, or there is no lung problem, and patient is not, you have checked drug chart, and patient is not any kind of medication. And ask patient, and maybe patient is not admitted in hospital, you ask patient is not any kind of medication. And you have checked all the tumors and everything, and what you do next? Please. Can someone answer, please? What is your next step to diagnose this problem? You need to think more critically about when somebody's low sodium. You have checked all these results are fantastic, no problem. But why? And patient is euvolemic. And what you do next? Your next step is to do proper clinical examination. When you actually do proper clinical examination, what you actually will be doing? You will be doing examining. So if you do somebody with the breast malignancy, that breast malignancy is not picked head or CT unless it is metastatic, any other organ. And so please, whenever you examine see any patient with low sodium, and if your diagnosis is SIAD, do not forget to examine breast and try to figure out the culprit. So hyponatremia patient. So what we are doing volume assessment. What we know, euvolemic, hypervolemic. So, and patient has diarrhea, you already know causes diarrhea, vomiting, diuretics, salt losing enteropathy. And euvolemic patient, you already know hypothyroid or adrenal insufficiency of SIAD, or hypervolemic patient, cardiac failure or nephrotic syndrome of cirrhosis. And you need to make sure it's the clinically hypervolemic. And then for a SIAD patient or the euvolemic patient, you need to do request for thyroid function test, short synaptic test for adrenal insufficiency or adrenal failure, and plasma and urine osmolality. And for cardiac failure, you need to do a proper assessment on a clinically hypervolemic patient. So for euvolemic patient, you need to do thyroid function test, short synaptic test, and you need to do, if you suspect CR, somebody have got CR. So you need to do serum osmolality and urine osmolality. Somebody with CR patient, you will get low plasma sodium. You will get high urinary sodium. That is actually telling you the causes. In your exam or in your clinical practice, you need to actually rely on urine test, actually serum osmolality and urine osmolality to diagnose somebody with CR. You might, you might ask me, Monjur, and you mentioned that euvolemic patient, you mentioned that at the beginning, ADH means, low potassium means more ADH, and more ADH means low sodium. So what is this excess water? When somebody when in our body there is excess water, body used to release natriuretic peptide. So because of natriuretic peptide, body lose water. That's why, somebody, euvolemic patient, sometimes you see patient are puffy, but if you do examination, you do not see pedal edema or all other things because it's a natural mechanism. When more water in our body release natriuretic peptide, they try to release water from the body. So that actually one of the causes for euvolemic hyponatremia. So that I mentioned in diagnosis of CR, low sodium, no hypovolemia, that's euvolemic, no hypothyroidism, no adrenal insufficiency, reduced plasma osmolality, and increased urine osmolality. And lab will never tell you that urine osmolality is high. This is one of the few numbers you need to memorize. When you see any patient with urine osmolality is more than 100, low potassium, and you need to think about possibly what you need to do very quickly to rule out the patient is not in a hypothyroid problem. TFT, you request for thyroid function test, you request for short synaptic test, and that's how you actually go and quickly diagnose CR. So now, very interesting part of how actually you treat somebody with hyponatremia patient and hypovolemia. So can somebody tell me how do you treat actually somebody with hypovolemia and hyponatremia? Can someone please say, how do you manage that patient? Please join me, please.
In case of water saline, we should take them, in case of water loss, we should take them saline, oral saline.
Okay. Okay, oral saline. Anything else? Okay, so what you do? Oral saline will not be as effective. You need to do actually volume replacement. You need to do hyponatremia and hypovolemia. So you need to replace volume with 0.9% saline. Well, try, you have got a back of your mind, you have got an answer, you need to correct that so. If this is hypovolemic patient, you actually need to correct both a volume as well as. When you actually infuse saline, why you actually not actually giving oral, when you actually infuse saline will cause shut-off of ADH. Your patient would get better, recover quicker. Sometimes you tend to see people are giving actually hypovolemic and hyponatremia, they're giving some salt. This is not be enough because once water is there in your body, then and that saline will cause a shut-off of ADH release from posterior pituitary. Now, difficult group. how would you treat somebody with hyponatremia and hypervolemia, heart failure, or and liver failure, or somebody with renal failure? How do you treat this hyponatremia patient? Can someone please answer?
Diuretics
There's something.
Diuretics may be used, fluid
Yes.
restriction, and
Okay.
treatment of the cause.
Fantastic. Well done. Diuretics in hypervolemia, yes. Well, what you told, I'm not disagreeing with you, but before that, you need to do first thing, fluid restriction. Okay? Because more water, in your body is more water, that's low sodium. So you need to restrict fluid in 24 hours maximum. And what you told, you answered this question, this answer, treat the underlying cause. You're giving diuretics, fantastic. So, but before actually doing that, you need to do fluid restriction and maximum of 750 ml in 24 hours. What you need to do drugs, check drug chart. And in 24 hours, fluid restriction, 750 ml, which includes, if you see in the ward, in hospital bed, you see, in a patient's medical note, a patient on fluid, maximum 750 ml and 24 hours. But at the same time, you see the antibiotics is running, infusion of antibiotics, vancomycin or other antibiotics here. So you have restricted with your saline, but you ignored the infusion that the antibiotic you're giving. So you're actually not strictly maintaining your 750 ml of fluid restrictions. So when we say 750 ml of fluid restriction, that include any kind of other infusion you are giving to your patient, okay? So, severe hyponatremia, okay? And this is when somebody has got very severe hyponatremia, so then you need to actually reduce Glasgow Coma score on seizures, and you need to keep them hypertonic saline, 3%. And actually, in clinical practice, you do not make this decision until and unless you are really expert of that. You need to seek advice from senior health, those who had got experience of like giving hypertonic solution. And what kind of hypertonic, what percentage of hypertonic solution you give in Bangladesh? I'm actually long back, I have left Bangladesh. I don't have a current idea of Bangladesh. What percent of hypertonic solution you are giving in Bangladesh? Here in Britain, we are giving 2.7% hypertonic saline solution for severe hyponatremia patient, but with the expert, very expert in somebody in critical care medicine, or somebody in endocrinologist, they can understand. And so, and whenever you see reduced Glasgow Coma score and seizures because of hyponatremia, so if you figure out this problem, because of hyponatremia, patient has reduced Glasgow Coma score and patient develops seizures, then you need to think about hypertonic saline. In Britain, we give 2.7% saline. But for Bangladesh, to be honest with you, I do not answer which one you are using. But you need to, as soon as possible, you need to take advice from your senior. So, one important point to remember while correcting hyponatremia, okay? Serum sodium must not be corrected more than 8 to 10 ml in the past 24 hours. This is very, very, very important. So what do you actually need to do? Say you've got somebody's serum potassium is 110. So in 24 hours, how much you want to correct? Can someone say me, please? Answer me, please. 110. How much you want to correct? In next 24?
120.
Sorry, 100?
10 millimole correction.
Fantastic. So 120 is max limit. It's better, in being the stage of 180 millimole would be better, but max is 120. Because if you correct sodium too quick, there is a risk of osmotic demyelination, central pontine myelolysis. So what you will see, so you have corrected somebody's potassium and, somebody's sodium too quick. So it was 110 and you have given too much of correction, it is 125. And the day 2 or day 3, you will not actually realize, if you keep on very quickly correcting these things, what's gonna happen? It will go to the brain and it will cause an osmotic demyelination, and it's called central pontine myelolysis. And you even do not recognize or realize how, because of ignorance or lack of knowledge, how actually, because of lack of knowledge, you actually kill the patient. So you need to be very, 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 very mindful thinking about it. Well, low sodium, and I shouldn't correct more than 8 to 10 millimolar in the past 24 hours. So, however, if you see you have corrected too much, 125 millimolar, so what you need to actually give diuretics to give diuretics to and correct this sodium to bring it to down. So if you ignore that, and if you keep on going, first I have corrected for 110 to 150, 25. Then secondly, you have got 125 to 140. And in 40 hours, 48 hours, you see your patient's sodium level is normal, you are happy. But in day 3, you saw a patient is dysarthric, a patient has dysphagia, seizures, coma, and patient can die if you miss that. So this is one of the key slides from today's talk. So whenever you actually correct sodium, you must not correct it more than 8 to 10 millimole in the first 24 hours. Normally, demyelination syndrome develops 3 to 5 days later. This is one of the images of central, this is on in the pons. It can develop actually in anywhere. So central pontine myelolysis. And because of, this can develop because of low potassium, and you have corrected too quick, and you are greedy to correct sodium too quick. And in day 3 to 5 days, your patient develop, all these features and dysarthria, coma, and patient dies. You need to be very, very careful. So whenever you actually treating CR, so your first job is to, and actually water restriction is insufficient. So what you need to do, you need to actually do demiclocycline that actually reduce responsiveness to collecting tubule cells to ADH. One of the problem with demiclocycline, so, and this is, but you don't actually need to, if you simply actually restrict food, it will help you most of the patient, but some patient you need to do demiclocycline. Another drug we use, not very commonly or not frequently, is expensive, tolvaptan. It actually work on V2 receptor antagonist. So, and this is expensive. So you actually, so, and also whenever you use tolvaptan, so you need to actually, you need to contact with clinical pharmacologists to discuss about what's going with the patient. So most of the time, then CR patient could be treated with simply with what? So, now, got a quiz for everyone here. Okay. Hyponatremia, I have got given 2 choices. Okay. Hyponatremia is mostly due to choice A, a reduced body sodium, is increased extracellular fluid. If you make a mistake, you will shoot on my head. Which one is correct? A correct or B correct? Hyponatremia is mostly due to reduced body sodium.
A, sir.
How many of you are with A? Or how many of you are with B?
B.
Who do with B?
B, sir, B.
B. Anybody with B, or how many of you are with A?
B, sir, B.
B. Okay. So I already got, actually, one of you actually shoot me on my head. Okay. So what I mentioned, hyponatremia, reduced body sodium. Okay. So increase body extracellular water. Whoever said B, they are correct. Someone also mentioned it's reduced body sodium. I mentioned at the very beginning of the talk, hyponatremia is not a solved problem, is problem with water, increased extracellular water. Unfortunately, I got shoot on my head, okay? So I need to run to A&E to fix my head because I already get shoot. So whenever you see any hyponatremia patient, you need to work on like whether the patient has got, because more ADS release, that means more ADS release, which means more water is retaining extracellular water, more extracellular water, which means that low sodium. This is how far I'm for today. Any question, please? If something is not clear to you. Please feel free to ask me. Feel free to ask me, please. Something is not clear? Is not clear? Any question from anyone, please? Any question, please? Are you happy? Have you got some kind of understanding about hyponatremia? Any better understanding of hyponatremia, or are you confused?
So I have a question regarding hyponatremia correction. Sometimes we use some formula regarding correction of hyponatremia, but this is sometimes confusing that which formula we use in case of which type of hyponatremia. Sometimes create confusion.
Okay, so let's make it clear. Okay, fantastic. And okay, so I'm going back to this slide. Okay, so you have got somebody with low sodium, which is in hyponatremia. So what you did do the volume assessment. Okay, so when you do volume assessment, there will be 3 types of volume. Either it could be hypovolume, that is in our body, volume is low, or it could be euvolumic, that is there is no problem with volume, just sodium is low on blood report, or it could be hypervolemic patient. Low sodium at the same time, the patient is edematous, or JBP is raised. This is how actually we do volume assessment. Then what we do, then we need to actually pin down causes. And you got somebody's low sodium, and patient is hypovolemic. So, and you got a patient admitted in A&E or somewhere. What you do quickly volume assessment. If the patient is a low volume, if you actually you start any kind of fluid, if you quickly check urine sodium, if it is actually less than 20 millimole urine sodium, that will actually help you to diagnose the problem. So in hypovolemia with low sodium, then urine sodium is less than 20 millimole. So you might think about, well, this might be used as hypovolemia. So I can very confidently keep 0.9% saline, and fluid restriction is not I don't require that, okay? The quicker I actually replace volume with salt, I mean, 0.9% saline, once volume is replaced, then it will shut up ADH release. There's one ADH, I mentioned that more ADH means more water means low sodium. So once I stop, stop releasing ADH, which means I am actually, body is retaining less water, so salt will be corrected quicker. So, and this is the volume, hypovolumic. Euvolemic patient, and you got, there is no urinary sodium is not less than 20 millimole, volume is fine, but you have got problem with thyroid problem, hypothyroid or adrenal insufficiency, you can do synaptin test, or you can actually do CR. So this is volume is not a problem, and it's just problem with a low sodium. And then you have got hypervolemic patient that's easy to diagnose. Patient might have got heart failure or renal failure or cirrhotic patient. So so whenever you see any patient, you need to actually ask yourself, is that patient is clinically hypovolemic? Number two, is the patient is, for euvolemic patient, is the patient have got thyroid problem? You need to do a function test. You need synaptin test to rule out adrenal insufficiency. You need plasma and urine osmolality. So, and then if you suspect somebody with heart failure, you can actually do, and you can actually rule out pulmonary edema. And also you can do anti-proBNP out, recommend anti-proBNP, other BNP. And also nephrotic syndrome, you can actually secrete in liver. Cirrhotic patient, you actually can, you can there liver function test, low albumin. These are the things you can actually quickly rule out when you actually start investigation in your patient. Did you get your answer now?
Yes, sir.
Okay. Any other questions from anyone, please? So any question from anyone?
Question, sir. I have a question, sir.
Yeah.
Why there is no hypervolemia in case of SIAD?
Yeah. No, if it is SIAD, there cannot be hypervolemia, it cannot be a hypovolemic. It has to be euvolemic. Let me take you the one slide I prepared actually. For diagnosing SIAD, look at this slide. For diagnosing SIAD, it has to be low sodium for us, no hypovolemia, no hypothyroidism, no hyperthyroidism, no hypervolemia, no adrenal insufficiency, reduced plasma osmolality. If with somebody with low sodium, and if with these other points I mentioned, if this criteria, only then you can call it SIAD. Is it clear to you, SIAD? Did you get him answer, please? Hello?
Thank you, sir.
Any other question from anyone? And if there is no more questions, can I actually draw the attention of admin team, and I think probably we could conclude our session today. And thank you very much, everyone, to join this talk. And I think probably it will be recorded. I think whenever you have got a free time, probably you can go through the slides again and watch it again. Probably it will help you to understand better hyponatremia problem. Admin, please.
Sir, thank you. Maybe there are no questions from audiences.
Okay. Okay, so can we say thank you to everyone, and thank you, Lancet team, to invite me, and all the participants, those who have taken that very late at night, and thank you for joining me today. I hope that this talk will help you to think sodium problem more critically. My only advice to you, those who have joined this talk today, you try to work with pathophysiology. It's not with the low potassium, any disease. What is the underlying mechanism? If you understand underlying mechanism, that will help you to understand managing your patient better. Thank you very much.
Many thanks to you, sir, for giving us your important time and discuss on a very important topic today. We hope that you will give us more interesting sessions in near future, inshallah.
Inshallah. Okay.
Thank you,
thank
sir.
you.
Good night, sir.